I have this perspective that I'll share as a researcher. I'm a sociologist. I don't do any hands-on clinical work, and I just marvel at what you all do. So miigwech for inviting me, and I'm going to share, if you go to the next slide, a couple of things with you today. First, this issue of trauma. It's big, right? We could spend like an entire class or PhD program studying it, but I'm just going to think about it and talk about it in terms of how we hear from our community partners about root determinants of substance use inequities in our communities, and that has to do with historical trauma. And so I'll mostly focus on this idea of historical trauma for the brief time I have with you, and share with you some of the research findings that are out there today. So we can go to the next slide. I didn't know who our audience would be today. I know that this is sort of an open forum, so just to get us all to the same baseline, it's important for us to remember that tribes are so incredibly diverse. So I see that all of you are kind of bouncing around mostly the Midwest and Minnesota. And so you might encounter Dakota, Lakota, Nakota, even, of course, Ojibwe communities. And all of us are very different. And even within our communities, there are villages with such distinct cultures about them. And so I share that to say that there is no one size fits all approach or way of understanding these complex issues. We know that there are many federally recognized tribes here in the US. We are, as a group, Native people are growing quickly, about double the rate of the general population. Most Native people live in urban areas or off-res lands. So it used to be the case, like in the 1960s and 70s, that most Native people lived in rural reservations, and that's not true anymore. And the other thing I'll say is that in tribal communities, most of you probably know this, but we really do experience some shared social determinants of health that are similar to all humans, and some that are really unique and are a byproduct of colonization. And even across tribes, the way that that unfolds and manifests can look really unique. So this is all to say that I think it's worth spending time on those unique social determinants that relate to tribes. So next slide. So today, we're gonna really focus, like, what are the root causes, right? So in your clinical work, or if you do work one-on-one with patients or one-on-one with individuals, you're going to hear all kind of what we call like ideological agents, right? Like, what are the causes of what we see in front of us? But the root causes really, I think, are shared when we think about inequities. So in the case of opioid-related overdoses, we know that the national data suggests that 2 states in particular, up until 2015, were hit the hardest in terms of inequities, and that was Minnesota and Washington State. And in those 2 states, Native people were dying at a much higher rate than non-Natives. So what is the cause of that population level inequity is really the thing that I, as a sociologist, try to think about, right? So the individual pathway to get there might be distinct, but at the group level, what are the root causes? And I would guess that most people on the phone or on the Zoom or on the web have heard of this idea that your zip code matters more than your genetic code, or this idea that 70 to 80% of our health is socially determined. And you can see that on the pie chart on your screen. So things like social and economic factors, health behaviors, clinical care, those are the things that really come to influence our outcomes. And in this case, the outcome is substance use, right? And so in tribal communities, the thing that we hear over and over is that the root cause of, or those social determinants, really relate to stress and trauma. So next slide shows you a little graphic. Okay, so there's lots and lots of ways you could think about stress and trauma. As a researcher, as a clinician, I borrowed this from Blair Wheaton, who's a sociologist in Canada. There's a lot going on in this slide, but the bottom line is this. Trauma and stress could be thought about at sort of micro or individual levels, could be thought of at what we call meso, or sort of in between levels. So it could be interpersonal or community, and even at macro levels. So at the societal level, how do stress and trauma impact individuals and communities, right? And there are little gray, or what's the color, green boxes popped out on this slide that give you concrete examples of what that might look like. The other thing that I really like about this conceptual framework is that we can consider stress and trauma in terms of very discrete things, like a life event where someone passes away, or I get into an accident, or I have a very traumatic birth story, or whatever it may be, to the very continuous side of things, which means things like chronic poverty, chronic neighborhood disadvantage, chronic unemployment. So we throw all this together, and what we come up with is this thing called a stress universe, where you could imagine anything within that stress universe could impact health outcomes. And there's a robust literature, hundreds of years old now, that really lets us know that these kinds of things, stress and trauma, oh, there's a little background noise. Stress and trauma are really the things that lead to distress. Uh-oh. Is there a way to mute? I don't know how to mute. There's some overlap in sound. On your end at the echo office? Yeah, you got it, good. Okay, so this idea that stress and trauma create distress, and distress can look like a lot of things. Today, what we're worried about is drug use. Next slide. And stress, trauma, and addiction, I don't need to tell this audience, huge literature. There's a few reviews I've popped onto the screen, a famous face you probably have seen before. And just this idea that stress, trauma, and addiction could be linked is not a foreign concept to us. Next slide. But what may be less familiar to some people is this idea from tribal perspectives of historical trauma. So this is a quote from an elder and service provider from a First Nation community in Canada. And she was saying, you know, the stuff that we're studying, drug use, opioid overdose, methamphetamine, suicide, all of these are just symptoms of a deeper problem. And the deeper problem to her was residential schools and historical trauma. She was talking about this idea that historical events have led to us losing pretty much everything. Next slide. And there are concrete, there you go. Concrete definitions in the literature about historical trauma. The most famous comes from Maria Yellow Horse Braveheart. This idea that trauma can be cumulative, it can be emotional and psychological, it can occur across multiple generations, including the trauma I experienced in my life. But the root of it comes from a massively traumatized group history. And what's really distinct about these things, and this comes from the work of Karina Walters and Tessa Evans Campbell, is this idea that historical trauma is widespread. It generates high levels of collective mourning and distress. And here's the big thing for me. Historical trauma is important for studying health inequities because it didn't happen on accident, right? The events across history and in today's society that create this thing called historical trauma were done on purpose. The government policies were enacted with a purpose in mind to either assimilate or terminate, right? And so we just keep that social injustice in mind as we move forward. Next slide. So if there's one thing that you take from all of what I'm going to show you today, which is just a few more slides, it's can we shift our thinking about, in this case, substance abuse and opiate misuse, to one that look at a person and see them as something pathological or sick, and instead shift our thinking to, okay, can I consider this as a social response to a lot of social determinants of health, right? So this idea that our outcomes, that it's suicide, drug abuse, these might be considered a reflection of collective disease, and that this reflection is rooted in colonization and historical trauma. Next slide. So we have brief time today. There's a whole literature on how this broad idea of historical trauma can like drill down to affect individuals. And I'm going to very, very briefly fly through just a few examples of this, just to get people thinking again about that shift from personal pathology to collective response. So the first, historical trauma could be a causal agent, right? Like if I live through a historically traumatic event, it might impact me. The second is that historical trauma could be the anchor, the root for intergenerational issues. The third is that historical trauma is also an anchor for what we see happening in our society today. Next slide. So the first, this idea that historical trauma, living through these, yeah.
I think.
What was that?
Oh, sorry.
I thought I heard my name. No? Okay, keep going. I thought I heard someone say Melissa. It was this ghost. All right, so the first, this idea that historical trauma can be something we live through, right? Like a historical traumatic event. So a classic example in the US and Canada is boarding or residential schools. This idea that children were taken from Native families, thrown into these white or missionary or Christian-based schools. And what we know from decades of research now is that people who lived through that actually felt overwhelmed as parents, felt inadequate in their parenting role, and that the next generation, so the descendants of boarding school survivors, reported higher levels of neglect, abuse, and confusion about how to be a parent themselves. Next slide. So we use this idea, I know this is a lot going on the slide, but I'll just verbalize for you what's happening, and if you want the article, I can send it. But really there is evidence now of that intergenerational transmission that is rooted in historical events. So this is a model where our team just used one government policy, which was urban relocation in the 1950s, and used that as an anchor to kind of demonstrate how over time each successive generation had new issues that were rooted in that traumatic removal to an urban environment out of one's culture. So with removal came more substance use problems for the grandparent generation, which led to inadequate parenting and CESD as a measure of depressive symptoms, which then turned over into more inadequate parenting, which then turned over 3 generations later to the kids having higher levels of depression and delinquency. So 3 generations of effects rooted in one single historical policy, and we found evidence that that held up statistically over time. Next slide. We also know, this group knows about adverse childhood experiences, and I just wanted to briefly say that, of course, we know that that relates to substance use outcomes. And there's evidence that that's true in Native communities as well. But one thing that our team has recently been working on is this idea that in addition to ACEs, we can experience benevolent childhood experiences, or BCEs, and that in statistical models, when you account for both ACEs and the positive BCEs, it's actually the positive that outweighs the negative, which is really cool to think about in terms of interventions and really getting clients or patients or people you're working with to consider some of the strengths-based approaches to their own healing, that these things seem to be working out. Next slide. The other thing, and you can hit enter, I think there's another couple of bullets. There we go. So the last thing in terms of historical trauma I wanted to briefly is that historical trauma is only historical in that it started a long time ago. The effects linger on, as you can see. And one way that people are really starting to think about this now is through ongoing marginalization, or this idea of historical oppression. So those historical anchors have to severe funding of, for example, Indian Health Service and the amount of money we allocate to urban Indian organizations. We know that Native people in America are more likely to live in poverty than the US overall. We know how we are perceived in the world of sports, in the world of the national audience. We're stereotypes caricatured in the world of Hollywood Indians, et cetera, and so forth. There might be one more. We also know that we internalize some oppression. There's some lateral violence issues. And last bullet here should be that discrimination, which is a huge factor that is next to drug use, is reported most among Native people compared to other racial, ethnic, or political groups. Next slide. So to close it out in a nutshell, in our brief time, if you just had to kind of give a bullet list of what I've talked about, think about historical trauma and ongoing oppression as influencing everything from intergenerational exposures to stress, to the way that we experience stress in healthcare systems today, how we access healthcare systems, the quality of those services. We also know that a legacy of interactions with providers and government agents has been linked up to an unwillingness to seek care or a lack of trust in the healthcare, especially the medical system. This is huge in terms of medication-assisted therapies, as you all know, and huge in terms of the way that Native patients are discriminated against, especially in urgent and emergent care situations, and that's been documented in the literature. So the next slides for you today are just some references if you want them. I know this is super fast and brief, but there's plenty out there I'm happy to share. And the final slide is just some funding acknowledgements. And I know that you all are jumping into your cases, and I'm able to stay on the line for just a few minutes. And just again, want to thank you for the work you're doing, and hope to join some of these echoes in the
Just so
future.
you know, Melissa, we have lots of time, so take your time.
Oh, good. Okay. Yeah, so I don't know if anybody had questions. I heard someone say my name, I swear it.
It was probably just somebody who unmuted themselves, you know, by accident, and so we probably heard from them. Okay, so does anybody have any questions for Dr. Walls?
I have a question. Just because I know some of your research and some of the work that you've done, can you kind of share a little bit on how this applies to different treatment models or culturally responsive care?
Yeah. Yeah, so I think, you know, today I was asked to talk a little bit about trauma, and it's so that's why I focused on this. But the counterpart, or the other side of that story, and the thing that our literature really shows, and some of your work too, Laurel, and others, is that culture and community are like the most robust predictors of positive outcomes we can find. So whether it's recovery from substance use problems, or just protecting kids from early onset of use, or feeling like you're in a healthy space, which may not mean abstinence, but it may mean you're like healthily, you know, you're living in a healthy, in a good way. It's culture and it's community. The issue is like, what does culture mean? So I think that the thing we run into with providers, or with treatment facilities, or with like, sometimes we work with the treatment court systems, is this idea that, oh, you hear a presentation where someone says culture is helpful, and then people just want to throw in a quick like talking circle, and of course talking circles are amazingly powerful, but it's more than that, right? It's about values, and about culture, and about inclusivity, and about how do you build this kind of support system up. And so the very simple answer, culture and community, is very, very complex.
Thank you.
Yes, Carrie.
Thanks for the great talk, Melissa. My question now, being in an environment where I serve people of a variety of communities, is what is like a practical either next step to educate myself outside these echoes and other things, or something I should avoid so I'm not causing more harm? Like, I'm just looking for some concrete, like on the ground, how do I do something better, or how do I not make things worse in client care?
Yeah, super hard, right? I know, Carrie, we've had these kinds of conversations before, so I know this is like, I think the most important thing about that is, you know, it's a constant journey. But there's two things. One is there's a toolkit, and I can send this out to you all, on how to be an ally, in this case to Indigenous communities. And so that might be a useful thing. And I think, Carrie, I've shared with you before, like this idea of, instead of cultural competence, moving to cultural humility and cultural safety. And it's that idea that you can allow each person or patient to express themselves and their cultural values in the way that matches them, because it's diverse, right? And so those are two like big principles. And I'm curious, I'm going to throw it back on you, because you've been on this journey for a while. Have you found anything that's been really promising?
Nothing specific. I think the idea of cultural humility, and I just am going in with, you know, the 2 ears, 1 mouth, and use them in that proportion, and just trying to understand who people are and what their goals are, and then trying to tailor what I can offer to them in that way. Yeah. I guess I'm just always so sensitive to, you know, like not accidentally doing something really harmful to somebody else in what I'm saying or in my actions. And then also thinking more systemically, you know, about at any system level, but even at the center, you know, what do we have to offer, and how does that bridge across with other models of care that may be more helpful for specific communities? Mm-hmm. And that's the part too. I don't know. I'll look at the toolkit. I think that would be very helpful to me as a start.
Yeah, and then there's this, so I don't know if you all have contacted her, but Kamela Venner is a native psychologist down at University of New Mexico. And she published, I cited her, she published an article about barriers to MAT for tribal people. Oh, someone named Kamela just said hello to me. It's not her, is it? Wow, that was like another moment. But Kamela Venner's work, I'll send that out as well. I can send it to the coordinator who can share it with you all.
That'd be wonderful.
Thank you. And I'll just add too, I really appreciate those thoughts. I think that's great. And some of the work that we've done here at NAC over the years has really centered on getting the voice of the community. So having a council, an elder council who can kind of guide some of our policies and practices here at NAC, and then also just giving opportunities for the clients to provide feedback. And now we're starting this year a youth council as well to kind of give some feedback around prevention. So that's something that's really worked for us. Any other questions?
Hi, Laurel, this is Paulette. When you say works for us, do you mean works for you as people that are serving our people, or is it for our relatives, or what do you mean it works for us?
I mean NAC. Thank you for clarifying that. So some of the work that's come out of our racial equity project that we have going, it's actually something that's kind of a standing philosophy that we've adopted. It's not like an initiative per se. We want it to be embedded in the work we do. So we have a racial equity committee within NAC. And through that work, we've been able to bounce things off our elder council. And I can give an example, a tangible example of a policy that's changed. It's more internally. So one of the policies that we were able to amend was around what does it mean for family grievance. So when our policy was stated close family, and it named who those close families were, like a parent or a child. And we've expanded that now to be close as in how our staff identify those relationships on their own, just because we know within the Native community that we do have really strong relationships and with other people in our families. And a lot of times our grandparents can be like another mother, or our sister siblings can be like an aunt figure, but also a parental figure as well in supporting. So thank you so much, Paulette, for that.
Anybody else have any questions or comments?
Yeah, there might be a chat.
Is there a chat?
Oops, sorry. We have a chat question.
So Rebecca says, Carrie, I think the fact that you're aware and asking these questions says a lot and will help you in your care. And then
We're just supporting each other in the chat. That's what I think
Yeah.
is happening.
that's what I was looking at. Yep, everybody's supporting each other. And Carrie, I don't think you can see these chat messages, so I just wanted to make sure you know that everybody is kind of saying, you know, the fact that you're asking these questions and have this concern really says a lot. So thank you.
Thank you. And thank you so much, Dr. Walls. That was really a wonderful presentation. I'm sorry the time was so short. I kind of wish it had gone on longer.
Well, you may not watch that. I talk a lot. But I'll send out these resources, everybody.
Great. English.
Thank
In
you.
English.
Case presentation.
So we're going to move on to our case presentation. We've got Dr. Lauren Graber from Minnesota Community Cares. Thank you so much for submitting a case presentation for us to talk about. I'm going to turn it over to you to tell us about this person.
Thank you so much. I hope everybody can hear me. Are you able to hear me? Thank you. And I want to thank this group because I've been desperately wanting to participate more. And it's clearly I was running late today because I have a very, very busy Wednesday morning clinic. So I'm sorry that I haven't been able to more regularly participate, although I'm eager for your insights and a lot of your thoughts both on this case and for my program. I'll back up just a little bit to say that I'm a family doctor, so I take care of kids and adults. And I've been practicing and doing MAT buprenorphine for the last 4 years, I guess it is. And recently I took over as the program director for the substance use program here at Minnesota Community Care in St. Paul. We have about 160 patients who have been pretty stable in our program. 56% drive over 100 miles to come to our clinic. And so that is a proxy measure for a lot of our Native patients. We do have a handful of Native patients from the Twin Cities as well. But it does seem that a lot of people are coming from up north. And I think there are a lot of reasons for why people are traveling that far. I think that, especially in the beginning, I think part of it was worry about access. And then I'll also just kind of say about our program is that we, because we've been, the program that I was taking over started in 2011, and because of capacity was really giving patients prescriptions for up to 3 months, and with the buprenorphine mono product pretty extensively. And so now that I've come in, we're really doing some more protocols and trying to figure out how we can better support people. We're doing more testing, and we've actually, I think in that process, we're learning a lot more about our community and how we can support them. So that's just a little bit of background about my program, which I think is important. I really come to this very humbly, because it's been really hard kind of to bring in these different protocols, and then also how I can support my staff and everybody to continue to be sensitive to the many different needs, challenges, historical traumas of our patients. So I'm sorry if I missed the presentation earlier, but I imagine that there's just a ton of overlap with the patient I'm going to present today. So the woman I'm going to present you is a 25-year-old woman. She has been in our program since 2018, and she comes every visit with her mom. So both she and her mom are in our MAT buprenorphine program. Both of them are getting buprenorphine mono product because of reported allergy with nausea and headaches before. I first met them in, I believe it was September 2019. They, prior to that, had been getting medications and checking in with our clinic every 3 months. They did not have any check-in with our therapists at that time, but had been coming to see the MAT provider and getting good support. And I think in those interactions had support, but no real follow-up in between. So my big overall question, and I hope that I'm following the normal format of how you guys do case presentations. Thanks. My overall question is that, using a harm reduction lens, how do I support patients who are continuing to use meth but abstaining from opioids, and they're still taking the buprenorphine, and what kind of additional resources would be beneficial? So I would say we transitioned from, we've been doing a lot of urine testing here for many years, and then recently started doing oral swabs as a way to be checking in with people more consistently, especially when people were coming in every 3 months. And it was when we really switched to the oral swabs that we had a lot more positive methamphetamine tests coming up. And so that's very much been the case for this patient. Initially, the mom and daughter were always seen together, and then I was splitting them up, and so talking with them independently. And talking with the daughter, the first affect, the first impression is that she really doesn't want to be there and doesn't want to connect. She makes very little eye contact, even when responding to in questions, 1 or 2 questions, always looking away. And always when I'm like, how are things going in your recovery? Are there any challenges? It's always, nope, yep, maybe, very short answers. So I haven't been able to really crack into having a relationship with her. And she would always deny any use. And then when in the subsequent visit, when I come back and be like, I've been really concerned about you because your testing showed methamphetamines that was different than what we talked about. Can you tell me what's going on? She both would deny or say, oh yeah, I use that, and kind of be very dismissive. One time she was angry and like, you're not giving me my medicines. And that was also when I was talking about the fact that we as a program are switching all of our patients who are on buprenorphine mono product to the buprenorphine naloxone combination for safer reasons, and hopefully to help the larger community in terms of diversion potential. So when I was talking with her about that transition, she was very angry and saying, I'm going to get pregnant just so I can be on the buprenorphine medicine by itself. So long story short, I've been sort of in this ongoing system where I've been trying to offer support, actively connecting her with my therapy team. We're not really breaking in her. We see her every 4 weeks now and have her but only give 2-week prescriptions. She does a urine testing up north at another lab, and then once we get that testing, then we call in another couple weeks for her. And so, but I'm not changing that pattern. So in my rubric, when she's continuing to use, we're not changing anything. We need to elevate our care and support. And so that's why I've really come to this team, is because I feel like I don't have any resources 200 miles away from this patient to be able to support her. Are there other ways that I can, other programs, other connections, other ideas that people have about how we can keep her safe first, and then get the treatment that she deserves. And please let me know if you have more questions, or if there's anything else that I should, that I can fill in.
Sorry, we're having a hard time getting unmuted. So we really love it if people could ask questions of Lauren. Anything that else you want to know, or anything just to sort of, any more information that we need?
I should say, as I was preparing her case and like thinking about the topic of today, I'm so concerned about trauma for this young woman. From the immediate affect presentation to all the different subsequent, all of our interactions, the desperation. She's currently in jail, and sort of alludes to some of these more escalated assault situations that make me so concerned, and yet I really feel we're not cracking in a way that's effective.
Are there other resources that she's mentioned that she's used, or frequencies, outside of getting some sort of treatment?
She has been in treatment programs before, and then I think felt that they were too restrictive, and that's kind of what brought her to our program initially. CPS has been involved when her child was born, he's almost a year old, and they're not involved now. I've tried unsuccessfully to connect her with a psychiatrist closer to where she lives, so that we can, she reports that the reason she's using meth is because she has ADHD that's been untreated. And so I've encouraged, that's a way for us to continue to get better assessment, and also just have another person closer to her to continue to be connected. I've tried unsuccessfully to connect to her therapy. So I guess, so that's what I've tried. I haven't, in terms of what things have been successful for before, I think she said that the treatment before felt too restrictive, and I don't know much more about other times when she personally felt success.
What is her goal?
Great question. I think I need to be more explicit in asking that, specifically to say, like, what do you want out of this? Because I think certainly having and taking buprenorphine has been the pressing goal, that we get the most calls around when her meds don't come out. But I think that that's a great thing. A great question.
Is the buprenorphine consistently in your urine, and are you looking at the levels of the buprenorphine and norbuprenorphine?
Great question also. I can pull that up on my computer here. So the interesting thing about the oral swabs is that the buprenorphine-norbuprenorphine ratio is not accurate. So it does show that when the norbuprenorphine is positive on an oral swab, that implies that she has been taking it within the past week, but it doesn't tell me specifically about a better flow than that. In the past, she's always been positive for it. Ratios always had been appropriate when we'd done urine testing.
Whatever level.
The most recent one, her buprenorphine level is 392, and her norbup was 850. So, generally appropriate. And I think part of why we've switched to doing more oral swabs is because we'd had a lot of reports of people bringing in false urine, and we were not doing observed urines and didn't have the capacity to start doing that.
What dose?
So I have not changed her dose, that she usually does in divided doses.
Does anybody else have any other questions about this? Anybody on the chat?
This patient seems familiar, guys. Is this something that you all, patient, you brings up some things in your practices? Yeah.
Would she be opposed to going through neuropsych testing?
I don't think that she would be opposed to it, especially I think if it would provide her more resources and like support, support for real learning disabilities. I think that, that's part of why I'd intended to connect her with psych before. I just don't know how to get her there.
Yeah, we had a patient who said a similar thing about the meth and ADHD and feeling like, was sort of treating as ADHD, which, so we sort of puzzled that because of course you can't use the medications for ADHD as like we use Suboxone. It's not approved for that, but at the same time, so we talked to him about that and said, if you did the neuropsych testing, then at least a psychiatrist might consider something like that for him. But in order to do the neuropsych testing, they have to be off of meth.
Exactly.
For a period
exactly.
Yeah.
2 weeks, at least 2 to 4 weeks, I think. Yeah.
I have a question about something I read in the case presentation.
Yeah, please.
So it's written that she's currently incarcerated, but mom is requesting her medication.
That's right. So, and maybe so she's in jail.
Okay.
She's in jail, not in prison, but I believe that mom believes that she can bring her the meds so that then she can have meds while she's in jail. I have, with this jail in particular, I've had some luck that if I can get them to sign the CFR 42 waiver, that then I can tell them the dose of buprenorphine that she's on, and one of their providers can dose while she's there. So it seems like there's one provider who does that. So I don't think it's necessarily a like foolproof situation. And so that is how at this point, I feel like I can't, although if you all feel otherwise, I appreciate it. I felt like she's now missed an appointment. She's missed an appointment because she's in jail. And I feel like without having that other check-in, I feel a little bit anxious about just sending another week's worth of medicine in her name without keeping her to our treatment plan and our treatment program.
There are some signs that it's helping her, right? I mean, that it's in her urine, so she's taking it. So I think that's always a positive. Have you sort of talked to her about the positives? Have you said when she comes in, like
about the positive methamphetamines?
About her, like sort of emphasizing her strengths. Like you're taking the medications, you're showing up. That really, especially, I mean, I feel like that's really been my ethos. Is that something I could work on more? Probably. But I feel like that's really where I come in in that I'm so, with her, I saw her mom this morning, I'm so impressed that you came here, especially given all the hardship that you've gone through in order to get to this place, and really trying to come from that point. Like, it's amazing that you've continued to come here. What else can we do to make this better for you? What else can we, and then they'll say, well, we don't want to have to come down every month. It's like, well, that's a part of our treatment plan. So that, what else can we do to make this a better process? But I appreciate, and it's always, I feel like it's always good to be coming in from that perspective of like harm reduction. That's where we are right now. Did you have a question? Don't forget to unmute yourself. There you go.
Hi, and you weren't on earlier. I'm Carrie. I'm a pharmacist with the Center for Alcohol and Drug Treatment, and I'm a faculty member at the College of Pharmacy in Duluth. And I appreciate this case so much because I do feel like this is something we see frequently. And I might have missed this, but you said this person travels 200 miles to see you?
That is correct.
And there is not someone who'd prescribe Suboxone for her where she lives, or what is the story there? So
this is the historical problems with my program that I've been trying to sort of figure out and try to support. I think initially, there are people up north, and we've tried to connect her with some of the other larger systems. I think it's been hard. I think it's been hard to get her. I think it's been hard for her to get to those other places and like be patient with their wait lists, right? So I know like Sanford Bemidji has a 2-month wait list. And I think that she's also been dissatisfied with getting the buprenorphine naloxone combo. So I think that's part of what's kept her coming to our clinic for so long, is that we've continued to prescribe that. And to be really clear, I've had, like, that's been a huge concern for me when I brought the program. So that's but as of March 31st, buprenorphine only prescriptions will be written from our clinic. It will only be buprenorphine naloxone. That's something that we've done a lot of prepping over the last 3 months with our patients, that this is going to be a big change. How are you going to do it? What other program are you going to go to if not here? And I'm anticipating that there will be a lot of different, I'm anticipating that our patient population will be a lot less.
Would it be possible for those who are doing well on it, and you find maybe do well on the other, like in this case, where you would make exceptions on that? I've actually talked about this with every other substance use program in the Twin Cities, because I've just been so anxious about it, because we are, from a harm reduction lens, we have to be committed to people's recovery where they are. And yet it seems that the risk of diversion with the buprenorphine only medications, especially the amount that we're prescribing, is so high that without other supports closer to where patients are, I don't feel safe on a license that I can justify continuing it. And the hard part is, if I make an exception for one person, that then it becomes a real challenge around how do I not make an exception for everyone. And it's hard because this woman's in crisis now, and yet I feel like, you know, we sort of drew a line in the sand on that. And I mean, but help me.
I would completely support that. I think, you know, if we have a similar policy in our program where we, you know, we never prescribe the mono product. We don't even prescribe it for pregnant patients. I mean, it's been demonstrated to be safe. You know, for those of us who lived through sort of the opioid crisis days, you know, I think that is kind of a red flag for me. Just like, you know, a lot of people had these allergies to, it just kind of like sets off your alarm bells when somebody comes in and says that they can only tolerate the buprenorphine only product. So we actually have a similar policy in our clinic.
Yeah. And I am connecting people with allergists, and if there are clear medical reasons that people need to be on the buprenorphine, then I'm able to do that. But I think, especially when somebody's having a hard time engaging with the program, it makes me more for the safety of this community and myself, I feel a little bit more anxious around it.
Who's prescribing the buprenorphine only product and is comfortable with it? Carrie, as a pharmacist, do you have any on that?
Oh, I'm sorry. So the question was about prescribing just the buprenorphine only product. I think it's tricky, especially if you're giving more than, you know, a week at a time and with someone who's not engaged. And I do hear this. So I sit in on a Little Falls Echo as well. And I know Dr. Mattson in Ashland has a few people that she was doing that for, so she might be someone to connect with about why, as far as the tolerance issue. But I also wonder about educating them about making sure they're not swallowing it and that they really are letting it dissolve.
Yeah.
And talking about some other things that might help avoid nausea or whatever it is they're experiencing. I have heard that before, but for all the reasons you mentioned, I completely agree. It would make me uncomfortable.
We're offering observed dosing. Sorry to interrupt. We're offering observed dosing sessions so that when people do transition, we're going to be doing oxygen and heart rate monitoring so we can know whether or not they're having true anaphylaxis, but also doing a lot of pre-medicating. We'll work very closely with our PharmD here, so we're going to be doing pre-medicating as we can for some of the symptoms and really coaching people around how to take the medicines in a way to help them avoid side effects as much as possible.
In my experience, people report not necessarily true allergy type symptoms from the combined product, but it gives them headaches or makes them nauseous, things like that. So I totally agree, making sure that they're taking it correctly. But there's also a lot of different options as far as formulations. So there's an unflavored generic tablet made by Acorn that people tend to tolerate.
That's amazing. There's an unflavored buprenorphine naloxone product. We've been looking all over for this. This is great. It's from Acorn?
Yep, AKORN. I could even, do you want the NDC number?
Believe me, my patients, the other thing is a lot of my patients are requesting specific NDCs numbers, which is part of why I have more concern about diversion with the buprenorphine product as well. So I love, yes, do you want to chat it to me?
Yeah, I can certainly chat it to you. So what the pharmacies have, so Walgreens specifically has said that they can order this product in.
Okay.
You just have to, DAW with the NDC number. Yeah, it's pretty well tolerated. It doesn't have that weird citrusy orangey flavor. And then, MA currently covers all generic films or generic tablets and brand name films. So it shouldn't require prior authorization or anything like that. I haven't had a chance to really look into it much. I've also had a patient say that they were given a small cherry or strawberry flavored tablet that they put under their tongue with the buprenorphine to kind of change the flavor. And
Oh,
I don't know.
we've talked about giving people nerds candy.
Yes, yeah.
To see if that would help both stimulate like saliva and if it would help the flavor a little bit.
I have another kind of question, comment, thinking about somebody who is kind of so far and traveling so far, and just kind of being careful about using words that would maybe be, well, for example, just that somebody might not be engaging because of that distance. I don't think that's a fair thing to say. But also, and just so you know, I think, so Dr. Gonzalez, he's a faculty member at up in Bemidji, and he's done a lot of research around experiences of racism for Native people at Stanford. And not to say that, I mean, that's their only real option up there, but I also think as much care coordination as you can do, so like maybe calling ahead and giving, the report on what this person is dealing with and maybe some of the hesitancies of one there, I think sometimes that can soften the startup with another agency.
That's great. And so that we have a warm person to receive them and to be, I think that's really great. Are there other programs that you think I could know about that would support women and children, or that could further case management for high-risk families? I don't know if that's something that exists.
Well, there's a Minnesota Indian Women's Resource Center. Definitely. That's just right 2 blocks behind Native American Community Clinic. There's also the, well, she's not pregnant, right? Or she is, I can't remember. She wanted to get pregnant to get buprenorphine.
Right.
I guess, and also working with this community and our relatives, I would be more mindful of, going 200 miles out of your way to receive something that I feel they could get elsewhere, especially treatment. Like, you're white earth or cautious as to why they are coming to you all the time. And just knowing how well they know the system sometimes, just being mindful of that. But so that is a resource, but that you could also tap into. The women at the MIWRC they're experts in this area.
I get the sense that people don't know exactly where she lives, because that might help them pull together resources.
Thank you. I should say, so she's near Cass Lake.
Why is she currently in jail? Was there?
So I don't know. I clearly don't know the whole situation. She was brought in on domestic assault charges. It sounds like that she had an altercation with her partner and the father of the baby. From the mom's perspective, she was really hurt physically. And yet he didn't have any charges and she did. She missed a court date. And then when she missed the court date, she's been brought into jail until the next court date. So the other perspective that just for me, I just feel like, this is the same jail that actually I feel like I have a number of patients who passed in and out of, and it just seems so unbelievably unfair and overkill. And that people are kept for ridiculous reasons. And I don't have any other, despite all of the Suboxone patients that we care for, I don't have other jails that are pulling people in the same way.
That I, like, yes. So I sometimes, I don't even really ask questions sometimes why people are in jail, because it just doesn't seem to have any bearing on anything, except for that they're being traumatized.
Right.
Right.
So some comments from Rebecca, just questioning if there's drug court or wellness court that she could maybe connect with. And then she did mention that Leech Lake has a wellness court that could support her.
That's great. Do you think, and so and I'm really naive with how to connect somebody unless they've been charged with something in particular. Is there a way that I don't know how her use is impacting her jail time now, but is there something that I should do as a PCP that could help connect with those resources?
I think a care coordinator from your team might be able to kind of help with that handoff as far as a referral and providing some information.
So does referrals to a wellness court come from the PCP?
I just want to know that it's 1 o'clock, so we should likely wrap up. I think that was a really wonderful discussion. Thank you so much, Lauren, for bringing that case. Did anybody have any final comments before we
Yes.
Sorry, what was it?
There's some chats coming up.
Leech Lake has a women's service program, it says, as well.
Awesome.
Erin Dixon sent that in. She's a patient advocate.
We track other outcomes.
We're reading the
Great.
Sorry.
Yeah, don't cut out the system until I write down all these great resources.
Can you see the chat, Lauren?
No, they-
Yes, I can see it.
Oh, they can?
Yeah. they can see
Oh,
it.
never mind. I thought you guys couldn't see it.
Yeah, so thank you all for joining us.
Where's the final
Where was
slide?
the sign?
Thank you, everybody. Do you provide a summary afterwards that
Yes,
then?
and also a recording of this is going to be available online. So because our presentation by Dr. Walls today was quite wonderful, so you can log on and see that.
Thank you.
And then
I have it on the website, correct?
next, what's our presentation next week?
Next is health equity, presented by Lisa Sheck.
From children. Thank you all for joining us. Have a great
Thank you.
couple weeks. We'll see you soon.
Thank you.
Wonderful. Thank you, everyone, so much for your help.